So I thank Sadhna for helping me out and for coming in for the panel. And we are missing two panelists. Where we have already introduced the five esteemed panelists here, very learned people. Thank you. And of course, I have Shadab here. So this is the baby that we want to prevent. You know, this baby with high drops. So let's see what we can do. These are my questions. I think I'll skip these introductory slides because we just had them about the history of the RH system and isoimmunization. So it was as early as, 1963 that maternal prophylaxis was developed. And in here now, in 2023, Madam is saying that there is still not the adequate and proper use of the prophylaxis, which can so easily prevent. So this is the RH system. You talked about it, isn't it? So I don't want to waste time here. And what we have to remember is that there are other blood groups besides the RH. And in the WhatsApp group, you find a lot of people asking questions like, should I do an ICT in an RH positive? So yes, if there is anemia, if there is a history of high drops, because at least in AIIMS, I have seen a lot of cases of C. C can be very dangerous. And then comes Kell, Duffy, Kidd. In fact, we recently had a very interesting case which is called Japan, blood group Japan. There are only 4 people in India having that blood group. And this patient had come to us, and I appreciate our blood bank people who identified the blood group abnormality. And can you believe it, madam? Because I really must thank Aparna for this. She arranged for blood to be brought from Japan. We brought the blood from Japan. We paid for the airfare or for the blood bag. The blood bag was brought like that. And then we transfused to the baby 3 transfusions, 3 air flights for the bag. There was one donor in Punjab and he refused to donate. You know, I don't think God will forgive him for making us. So just to say that there are so many blood group abnormalities which can cause high drops. So that actually comes under non-immune high drops, So very often non-immune high drops can be actually because of a blood group incompatibility, which is not RH, but which is something else. So you need to refer those cases to a very good blood bank who will do an excellent workup. So as I'm saying that there are more than 400 red cell antigens. Mostly we know about ABO and RH because that is the majority. 95% would be that. Okay? So what happens is that the problem is when somebody doesn't have the antigen, when somebody is RH negative, and that person is exposed to a person who has another antigen which is lacking, like RH positive husband, then the woman will develop the antibody and that will cause havoc in the child. You already talk about incidence. In our blood bank, it is about 7%. Now this is about the treatment. So William Lilly, way back in 1963, did intraperitoneal transfusion. And the very interesting way, we didn't have ultrasound in those days. So he actually did those X-rays, could make out where the abdomen is. And taking the X-ray guided, because in 63 we had only X-ray. He did intraperitoneal transfusion and saved babies. Then, of course, we also talked about passive immunization, something more than 30 ml for 80 ml. And in AIIMS, it was Dr. Kamal Bakshi who did the first intrauterine transfusion in 1983, almost 40 years back. So, we can have mild, moderate, or severe. And basically, by definition, immunization is a process by which immune antibodies are produced in a person by the antibody of an antigen. So RH negative, you have RH positive, and then you have the problem. So a very quick outline of the management to set the stage. We must do an ICT. ICT will be the one which tells you whether this baby is at risk. And when the ICT titer is high, then we need to monitor the pregnancy for any fetal anemia. That's the only problem intrauterine. No jaundice. No jaundice because this is blood which is going through the mother, and whatever bilirubin is there will go to the mother's circulation. So anemia is the only thing that we have to monitor. How we'll monitor, we'll talk about. And then when we monitor, we find that the baby is anemic. If the baby is more than 34, 32 weeks, there was a time when we actually just gave steroids and jaan chhut gaya, pediatrician look after. But that is not the scenario anymore. So we take the upper limit as 36. And before that, with the expertise of intrauterine transfusion, we can do intrauterine transfusion so that we don't have to deliver premature babies. We can do the last transfusion yesterday, as I said, around 35 weeks, so that we can go another 3 weeks and deliver the baby at 38 weeks. And then we also have we must have the baby delivering in a center where there is facility for giving exchange transfusion. This slide I had shown, very old slide, 10 years old, where RH isomerization, we did photosynthesis maximum. We have problems sometimes when the mother is obese, there are abdominal scars, when the placenta is posterior, because we like to go to the, the cord insertion site. And then, of course, operator experience. So, with this background, let's start with the discussions. Let us have short and crisp to the point answers. So, Dr. Vandana, this is your patient. Gravida 8, my God, para 1 and 6, RH negative. But the interesting thing is that, though she did not receive she was not given antibody for the last 4 vaginal.
Yeah.
ICT was negative, very lucky.
Yes.
So, how do you follow her up, and what is the protocol for doing ICT? How often?
So ICT has to be done in a RH negative mother because we yet do not know that her baby would be positive or negative, although the chances are 40% negative mothers carry a chance of carrying a negative baby, and we are not used to doing paternal antigen. And paternal zygosity is not done, so we don't know the father is homozygous.
We are not used to do even husband's blood group.
Husband's blood, yeah, that is.
First thing.
Yeah.
Yeah, I'm saying, madam, I've seen cases. So, if probably this husband is negative.
No, the husband is positive.
Okay.
I saw the patient. So she got covered with NTD in 2 of her abortions. She got 6 abortions done, and 3 were her will and 3 were spontaneous. And the last was 2 years back, in which she did get a cover of NTD. And right now her ICT has been negative, but she has to be followed up with ICT done at the first contact, and then repeated every 4 weekly till 28 weeks, and then make it bi-weekly, twice a month, till if it turns to be critical, or if it doesn't turn to be critical, then the patient reaches the term.
Yeah, there is
Even
no
then,
need to do
even if you give, the titers have to be done because we do not know. If ICT negative, we give NTD. The NTD which is being given passively will not give titers above 1:2 or max at 1:4. But if in case she gets isoimmunized in 2nd or 3rd trimester, then how are we going to pick her
No,
up?
we are giving in the 3rd trimester. And it is expected
20.
that the dose that you give
Yeah.
is going to cover whatever silent
With
fetal-maternal
fetal-maternal
hemorrhage
hemorrhages
occurs
is there.
in the 3rd trimester.
Yeah.
We don't need to repeat because, people are repeating and then I get referrals. Titer is 1 in 8, what to do? And they get so hyper. It is expected to be higher.
On the higher
there.
side, right.
But not critical level.
Critical level varies in 1:6.
Because of pinkish discharge, you want to give NTD at this moment, at this
At-
dose. What you want to say?
No, not now.
Abhi nahi,
It is
not
how
now,
to monitor.
Yeah.
Abhi we are just monitoring her.
Yeah. No,
Yeah, her
once
ICT
you,
came to be
once you
negative.
give the NTD, there is no need to monitor.
Yeah.
ICT.
Okay.
Yeah. So that's why I just put this. That is why. The unnecessary stress. Unless, of course, the patient has hemorrhage. Or
If she has
we
an
just
event.
had a wonderful lecture on silent hemorrhage, and if you find that the NST is going sinusoidal
Sinusoidal.
pattern or there are decreased fetal movements. I have had a patient like this, madam, 5-star hospital, she was a minister's wife in Arunachal Pradesh. She used to come from there for ANC because her first child died. of PIH. Second pregnancy, ICT was found to be negative. Then at home, she went back and she found that the baby is not moving. So that was in the second pregnancy at around 5 months. And then she went to the nearby hospital, they said hydrops. Same evening, she caught a flight and came to Delhi to the private 5-star hospital. And then they saw hydrops and then they referred to me. And in the evening, I saw her because I got messages from the minister. Of course, I don't believe in ministers and all. Patient ka aa gaya, meri emergency, my responsibility. And then I did a transfusion in the evening. Hemoglobin was 1.5. She got immunized in that pregnancy. So we had to give very low titers and aliquots of blood, and then we saved that baby. I'll tell you our protocol. We go up to 38 weeks. As far as possible. As far as possible. I'll show you the charts as well. She named that child after me, you know. So basically, just to quickly summarize how we manage a negative non-immunized. Father's blood group, okay? Partner's blood group, whatever you say. And then if it is negative, manage with what we just said, like anything. But positive, we should immediately refer. I'm not going beyond that. So why all Rh negative do not get immunized, Dr. Vandana?
All Rh negative would not get immunized because maybe the baby is also Rh negative. And then ABO incompatible.
No, Rh negative delivering an Rh positive baby.
Rh positive.
Why they don't get immunized?
Okay.
Everybody, not 100%.
ABO incompatibility, because that is a major antigen and the fetal blood gets cleared up very fast in the mother, and so no time for the antigen antibody reaction. Or if the antigen is weak or the mother's response is poor or there is a variable antigen resistance, these are few causes when even with the birth of an Rh positive, then we do not get isoimmunized.
Yeah, this ABO incompatibility, I hope everybody understands, because the mother does not have this antigen. So as soon as, you know, the ABO incompatibility, A, B, somebody was asking yesterday.
In O,
No,
usually
she's O.
Yeah.
Yeah, it depends, right?
Usually,
ABO.
yeah.
Then what happens is that because for a Rh antigen to cause an immune response takes minimum 3 days. The Rh antigen will go to the mother. The Rh positive
Abo.
cells of the baby will go to the mother. I think I have a slide. And then after that, it will go to the reticuloendothelial system. Then it will cause antibody formation, takes about 72 hours. That's why we always say, no, within 72 hours, give it.
give it.
Then only. But by that time, the ABO incompatibility, the antigens already
kill
present will hemolyze the cell.
Hemolysis.
And so nothing will reach the Rh system.
yeah.
If anti-D is not given to this woman, you know, your 4 patients did not, 4 times she did not get,
Yeah.
then what is the risk of immunization? Are you worried?
I would be worried, but then only 15% of the patients are getting immunized. That is again the reason is the partner could be heterozygous, and at many times the lady is carrying a negative fetus. So then she would not get immunized. Again, the ABO incompatibility is there. Again, she would not get immunized. So these are the various reasons why the immunization does not occur.
Yeah. So what you said just now. This was a study which I did, long ago, and we found that in the cases of immunization, Rh immunization, there were something like 200 cases. No anti-D after delivery was the major cause. No anti-D after MTP was like in about 1/5. No anti-D after DNC after abortion, VA after abortion. So very early they were not giving it, but we found that that was the only history which could have caused her to have immunization. I even got one case of Rh positive blood transfusion. This is utter negligence. And this is the most dangerous one, inadequate anti-D. They got anti-D, but they were still immunized. So we'll be talking about what can cause this. Dr. Sonal, this is your case, 28-year-old, gravida 3, para 1, 2 abortions. She reports with hydrops at 24 weeks. ICT is positive. What does it signify?
If ICT is positive in an Rh positive mother, it means that some
And
antigen,
fetal hydrops.
some antigen in the baby has stimulated the mother to produce antibodies. Yeah.
Yeah, so this is a case of a not, you don't know. ICT is positive, na? ICT is positive.
ICT is
The
positive, so it has
ICT
to
is
be
positive, but the
hydrops
woman is
only.
RH positive.
She's not, this is not non-immune eye drops. It is ICT positive. So there is some other antigen which is causing antibodies in the mother, and the mother's antibodies are killing the cells of the
Yeah.
fetus.
So what could they be? So basically, you know, we detect ICT. This is just to see that this is how we do the indirect Coombs test. We won't go into the details. You just order ICT, and this is what actually happens. The RH positive cells in the baby go to the mother. They excite the immune response. They will come back, and then they will hemolyze the baby's cells, and the baby gets anemic.
The baby
So
gets
basically, that's the thing, and the mechanism is that.
I will like to say that in this patient, अगर किसी का after detecting high drops, you do ICT because RH positive, then routinely to we will not do. So
if
after
there is
detecting
hydrops in any
we
baby,
thought of that.
you have to first do ICT even if she's RH positive.
Actually, we still are not following that order. We are not doing ICT for all RH positives. We are only doing if she's coming with, yes, I mean the high drops.
Yeah.
Basically, if they come with high drops, they're not even high drops, then we are doing ICT. But in some countries, yeah, actually, recommendation to है नहीं, but we are seeing a lot of cases of non-immune high drops. Now, we are seeing a lot of cases of non-immune high drops compared to immune. You know, so we have other blood groups.
Yeah.
That is what I'm trying to bring out here. So let's go further. What are the various blood group systems antigens? You know, I'm
See,
talking
as
about the
per
other
the-
blood groups.
Yeah. As per the CD system, there are 5 antigens, that is C, K, E, E, and D. So the mother, the baby may have any of these antigens, and the mother will produce antibodies to these antigens too. So only if patient is, if the baby develops high drops in an RH positive woman, then you think about these antigens.
Okay, do you think ABO incompatibility can cause high drops?
ABO incompatibility.
No, you
doesn't
said no,
cause
any other blood group incompatibility.
antigen.
Yeah,
Antigen.
antigen only.
Yeah. Yeah. The other antigens.
So what I'm trying to say is that ABO is not dangerous.
ABO is
They
not
can
dangerous.
cause jaundice in the baby,
And
but usually it
yeah.
has not been found to cause. Some patients come, no, कि इनका blood group ये है, मेरे blood is it dangerous?
And it usually happens when the mother is O and the baby is either A, B, or AB.
Yeah, that is what
Only then
happens
it
in
causes
RH.
anemia.
We
Yeah.
are talking about what happens in ABO incorrect. Mother is A, husband is AB. So then, what are the other blood group incompatibilities and how dangerous are they?
See, there are other blood group incompatibilities. They say that there are 36 different types of blood group systems which are available. And there are 360 different antigens. So there is a whole lot of spectrum. And the Duffy, Kell and KID and MNS, they are the groups which are dangerous. And
Dr. Shalini, this is a question for you, 33-year-old, 4-1, RH negative.
Yes.
She is now, unlike the previous case, this is RH negative, which we are dealing with today, and comes with fetal high drops and IUD.
Yes.
What is the cause? I mean, we are talking about it only.
Yeah, so it is possibly because of the RH isoimmunization. High drops is the severe form of the hemolytic disease due to the RH incompatibility. The antibodies which are formed, they are in quite a large amount and they destroy the RBCs of the fetus, leading to severe anemia, which in turn causes a cascade of serious effects, like there could be, because there is a severe anemia, there is a like severe load on the heart, and there could be a dilated heart could be there. Then placental thickening is there because there is severe anemia. So to compensate that, the placental thickening is there, which could be more than 4 centimeter. Then there is a pericardial effusion, hypoproteinemia because the liver is damaged. Because of that, there is a generalized edema. That's how the term is high drops, like it is like fluid.
Yeah, you can
So-
look at the slide also.
Yeah, there is a
So,
scalp
this is
edema,
cardiomegaly,
ascites, and
ascites.
pleural effusion.
The liver is
Yeah.
literally floating there.
Yeah, yeah. So all these presentations we can see on the ultrasound.
Yeah.
And because it is the severe one, it leads to IUD. Because
yeah,
of
what is the
severe
hemoglobin
anemia.
you think in this baby?
It could be less than 2 grams.
And here you see the scalp edema has occurred. This is a
Yeah.
very bad prognosis, and that's why, maybe this is just heading for an IUD within an hour.
Yeah, in fact, the X-rays which was done in the previous times, they say it is like a Buddha position, which says
Yes,
because of
Buddha
the-
position, that
yeah,
was the time,
because
yes.
Of the
Because of the scalp edema halo.
Yeah, yeah, halo, because
Yeah.
of that.
So why the baby dies?
Yeah, because of the anemia, the congestive heart failure.
Ultimately
the
heart
baby's-
failure.
Yeah, congestive heart
Liver
failure. of
damage
the
also.
baby.
The
Yeah,
liver is
liver
damaged
damage.
as well, and mainly it is heart failure. And what about the baby? What happens to the baby after birth? Why
Connect
babies
to-
suffer?
Yeah, because there is a severe anemia. It is a hemolytic process which is going on. So there is excessive hyperbilirubinemia, and which can lead to the kernicterus, the
Yes.
jaundice, hepatosplenomegaly.
So baby can die basically of, again, first thing is is the heart failure.
Right.
Second thing is now the baby is outside. So there is jaundice.
Right.
Jaundice, and the degree of jaundice will cause problems and kernicterus, as you rightly said. So that is. So now, what is the chance?
I would just like to say neonatal period. We had one meeting at Reva. So that jaundice, actually it is sometime I will like to have your comment that it is, we have to identify sometime it is not kernicterus, it is not that, the chronic hyperbilirubinemia. So as an obstetrician we must be knowing in our round कि अगर बच्चा कैंची पोजीशन में या hypertonus है, that is the sign of chronic hyperbilirubinemia. And sometime what we say ना कि लोग झड़वा लेते हैं, थोड़ा थोड़ा पी लिया है, ऐसे ये सूरज दिखा रहे हैं. So as an obstetrician we also must identify that this baby is not looking good and it is not frank jaundice and the brain damage, but it is a hypertonia and that the seizure position. So something which I learned from there.
Dr. Manjusha, there is this 28-year-old Gravida 1, Rh negative, reports at 6 weeks of pregnancy. So now, what test should be done? She's 6 weeks.
First of all, I will confirm her blood group, as Dr. Shadajan Madam said, even her blood group was confirmed. So if she's giving me a verbal report, I will confirm that she's
Yeah.
really Rh negative. And then I am going to do for her partner or husband if he is Rh positive or negative. If he is Rh negative, then this is non-high risk and I can leave it and do routine antenatal test. But if he turns out to be Rh positive, I'll be doing ICT for this mother. And probably I may be adding torch at this level for this mother because
We'll not talk about the rest. We'll just stick to Rh.
okay. No, in Rh also, okay. Because in non-hydrops, if it turns out, then I may be in dilemma of toxo and cytomegalo.
So primary also
So I
you will
may
do
be
Rh, no?
I-
ICT. I just wanted to ask you whether in a primary you will do ICT.
Yes, I will
Yeah.
do because she may be
But do
hiding
you think
the
a primary gravida is at risk?
because she may be hiding the history of previous transfusion and previous MTP and all that which she may not, and
Yeah.
grandmother effect.
We can't believe
Chances
her
are very
history.
less, but still.
But
we-
normally, if everything is okay, first pregnancies,
No, they are hiding the MTP is also done premarital.
yes, yes, yes. But let us say that she's a very nice or a virgin girl. ICT first pregnancies are usually safe. First pregnancies are usually safe because it is after the delivery that the fetal-maternal hemorrhage is maximum, and if you don't know, then second pregnancy is the one at risk. So, and rarely, I have got cases like that, first pregnancy. – 28 weeks. Yeah, so. Yes. We were not getting it done. No, I wrote to Foxy. I think it was Pai's wife. No, she was the president that time. I said, "Here, isko change karo." She changed it because that time you don't have IUT. Now you have so many things, and this case that I told you, she was ICT negative in the beginning of pregnancy, and at 24 weeks, I did her transfusion at 24 weeks, she was hydropic. So it can happen in the index. Yes, that's what I'm trying to say. RH negative. Foxy के guidelines have changed. Every 4 weeks, मैंने change कराया वो.
And it is in William textbook
Yes, yes,
that
what
now
are
you
you
have to
saying?
do. Every 4 weeks.
Yes.
It is a new edition.
Dr. Deepika,
Next.
in this our first case, if we give her immunoglobulin at NTD at 10 weeks, suppose
Why? She's ICT
that
negative.
then she was ICT negative and she was having that pinkish discharge.
Pinkish discharge. No, IVIG is not meant for that.
No, not IVIG. I'm talking NTD.
Ha,
so then
NTD.
what happens to the monitoring? The monitoring goes away? No monitoring then.
What monitoring?
ICT will have.
Serial ICT.
Karna hai, because after half-life is short.
2 to 3 weeks it will vanish. It will only max.
That is in term. Ha.
Ma'am,
Grandmother theory.
another important thing is that
Anybody, please?
the dengue has been so common in our country for last decade. The dengue has been so common. So all the adolescent girls, RH negative girls,
we are
if
going
they
to
have
talk about it. We are
received-
going to talk
yeah,
about it.
Yeah. So that is
The
also a
question
risk factor
somebody
for
was
primary
asking, what is
gravidity.
grandmother theory.
Grandmother theory is basically a woman who is RH negative today. So she was in mother's womb. Her mother was RH positive. So there was a maternal fetal hemorrhage. And that is what sensitized, which is a silent sensitization. Nobody detects it. And when she becomes pregnant, she already has NTD antibodies in her, which can go and attack the baby and cause fetal anemia at a very early stage. It's a grandmother.
Yes. Can I just,
No, husband is still in picture.
Huh?
Husband is still in picture. If he's in RH
husband
negative,
is in the picture because
Husband
he
is
has,
always in
he has
picture.
produced a RH positive baby.
Nani positive. See, Nani
Husband
positive.
with a positive hai.
Husband
See,
with
can I
positive.
just elaborate little bit? What happens in the grandmother theory? See, what happens in every step of a RH hybridization? First of all, there is a primary reaction. That is not dangerous. I think I skipped that slide because it was too, मुझे लगता था basic था. So, then nothing happens in the first pregnancy, as I said, and after the baby is born, mothers get this primary immunization, okay? Second time she's pregnant, this is the dangerous one, the secondary immune response. So after the mother is sensitized by her mother, when she was in the womb, she becomes pregnant, she has an RH positive baby inside because of an RH positive husband, okay? So that's where the husband comes in. Husband is involved because he is now making her pregnant with an RH positive baby. And now the baby's antigen, RH cells positive cells will go to the mother's circulation. Secondary, very hyper response. So, not an amnesty, this is a secondary proper response. And then that is going to cause immunization in the first pregnancy. So it will be positive. That is why we have to do, madam, ICT in the first pregnancy. Now you're clearer?
So when it is coming,
Yeah, because it can come in many causes that the first pregnancy can be affected. Low. Very rare, but not negligible.
Mother theory is not the thing which is
Premarital
happening to
counseling.
everyone, but it explains some dicey situation that there.
I think we should avoid the social stigma, because grandmother theory is not very common, and then they will go to some other obstetrician and she will tell, oh, she must have had some abortion, that's why her ICT is coming positive. So in all unmarried girls, we should not do ICT.
Yeah, you should not.
Pre-pregnancy counseling.
Same, she will end up in divorce, even in pre-pregnancy.
Huh. No, but you must know that you can get immunized in the first pregnancy. So whatever is the cause, we should not go deeper than that. What is the indications and timing of antenatal NTD?
Routine antenatal NTD we give at 28 weeks to all female, and we do ICT before giving it. And another indications are whenever there is history of bleeding, like in threatened abortion or unexplained bleeding or antepartum hemorrhage, we should give. Any history of abdominal trauma, any history of procedures which we do like CVS, amniocentesis, fetal blood sampling. Chordocentesis itself is not an indication because here already the fetus is positive, where we are doing chordocentesis to
No,
see.
but you might do chordosynthesis for a malformation, na?
Yeah. So we after delivery also we give after doing the blood grouping, and we may do in versions we are not doing. Otherwise, after external cephalic versions also it was.
Nobody does it.
Nobody does
nowadays.
it.
So these are recommendations. We're skipping them. You said already that ICG is required before. Somebody was saying yesterday that is it required or not required, kuch keh rahe the. So Dr. Harsh, your center is doing intrauterine transfusions. So this is a case for you, patient with hydrops, how to manage.
She has come at 27 weeks with fetal hydrops, and ultrasound is showing all the features like that. I'd like to see her NMC please, whether it is less than 1.5 or more than 1.5.
What do you think it will be?
It will be more. It will be more. And I think she's my patient only, and in this case she was referred to us at around 25 weeks, 2 days, and with a titer of 1:2048 and with fetal hydrops. So we did her this thing, and it was 1.93 was the MCA piece. And it was her bad luck or our bad luck, I don't know, because patient was already on ecospray. So we had to wait. We couldn't do. So we had to wait for 48 hours. In the meantime, we gave her steroids also. And then after 48 hours, we did a photosynthesis and we did the IUP also. And at that time, the hematocrit was 3.2 only. And we could transfuse 80 ml of this thing blood. That was given 80 and this patient was all right, and we were repeating her MCA.
Use the mic.
MCA PSV, we were repeating every this thing daily almost. And it came down to around 1.5, then it again started rising. And within a span of just 5 days, it again became 1.8. Then we had to transfuse again. So when we were transfusing, at that time the fetus developed bradycardia. And I had to do the cesarean. It was just 26 weeks plus. And baby was just 990 grams. Maybe it was due to the edema also, the baby was having the weight was little more. But luckily we could save this baby, and baby had exchange transfusion and all. And it was very good, our neonatology team, and we were in NICU. Yes.
Yes. So basically what we do is when a hydrops comes, she said middle cerebral artery, you expect it to be high, more than 1.5 moms. Then we should do a cord blood sampling. At the same time, we must have blood ready. And then normally when we do the hematocrit, the question actually was to you, but we're skipping it. So hematocrit less than 30, we should do a IUT. So we have to have a preparation for IUT. And this is how, see, the baby is hardly 500 grams. Imagine finding your vein and finding a vein in that baby. So this is how we do, and blood is very, very important. So this blood is, here I'm giving padcarinium to the baby, okay? I don't know whether you saw. Did you see giving the padcarinium? Okay, now this needle is coming in, huge placenta, and we are going to go to the cord. Vision becomes very difficult because of the placenta. It's a huge placenta which is there, the cord is there, and with a thrust we go into the vein. And then we start the blood transfusion. We are not going drip by drip. We have to push. So this packed cells, I put it in the thing. And this is a free loop of cord, very difficult. Try a Foley's catheter and try to put in a needle, you'll see. So different sites, you can see the blood flowing here. blood is going through all the and color Doppler to see that the blood is actually going there. And this is a very early pregnancy. You can see hardly 20 weeks. Luckily, the placenta, there. The needle has gone into the vein. And then we are pushing blood. So you really needed very dedicated, knowledgeable assistants with steady hands, because the needle, the person doing the IUT, and you can see the RBC is going. So this is a posterior cord, very difficult because long, uterus has to go through. We need a very special long needle. And then we are going to it very often slips. So, there, ekdam you have to trust it and push it. And then you can see the needle inside the vein, you're pushing blood. And here blood is going. This is a very early pregnancy. You can make out this is hardly, and the blood is flowing, and needle is going out, and we check the heart rate after that. I remember somebody who was trying IUTs for the first time called me up. Don't you use 2 transducers, ultrasound, one for the IUT and one for the fetal heart? I said, no. I have to concentrate on my needle. I can't go and see the heart.
I think we have covered 18 years, adolescent girl unmarried, she is coming in medical abortion. So whenever it is like, na to friend, fiancé, everybody is in hurry, they don't have much money also. So what's your protocol? It will be simple takeaway. Unmarried 18 years girl coming.
Would like to cover, because we do not know. She's 18 and she's getting...
पहले आप blood group कराएंगे.
Blood group has to be done.
So one thing which I've emphasized in this thing, that whenever you prescribe medical abortion, actually the minimum investigation protocol which is recommended is hemoglobin and blood group. It is not ultrasound which any professional body is recommending, whatever we are doing. So that is must, that उसकी हरी में हम लोग हरी ना करें. So that is blood group RH typing. और अगर वो अब उस पे नहीं जाएंगे प्रोफेशनल बॉडी, बट दैट मिनिमम लोग अल्ट्रासाउंड कराएंगे लेकिन ब्लड ग्रुप नहीं कराएंगे. व्हाट इज हैपनिंग? एंड सेकंड थिंग, जब अगर वो RH नेगेटिव है तो आप मेडिकल अबॉर्शन में व्हेन यू एट व्हाट मोमेंट ऑफ टाइम यू एडवाइज
ideally it is said to be given with the misoprost, but I think that that misoprost is being given 48 hours later only. Once we give mifepristone, so mifepristone is the first injury where the sensitization should start. So I usually give it with the mifepristone, but it doesn't matter.
No, you are doing right. Actually, it is to be given with Mifegest only. So with the Mifegest, with Mifegest, it has to be given.
Yes.
And if it is BSV is coming with now 150 ml, अभी क्योंकि 300 अभी तो नहीं मिल रहा है.
Right.
नहीं, वो दूसरा सवाल है. So this is one very very simple thing जिससे कि हमको ज़्यादा मैडम को इंट्रायूट्राइन ट्रांसफ्यूजन नहीं करना पड़े. दैट इज़ द थिंग व्हाट वी आर हैपनिंग इन डे टू डे. सो वी आर मिसिंग दीज अपॉर्चुनिटीज एंड दैट्स वाई वी आर गेटिंग दैट रेफरल. सो कितना भी पेशेंट कहे जल्दी में नहीं है, हमारा काम ब्लड ग्रुप RH टाइपिंग है, नेगेटिव है, मेडिकल अबॉर्शन, then with Mifegest, if surgical abortion, immediate after evacuation. So that is thing. और उसमें आपका 150 मतलब ये unit चलता है if it is available. Not available, we have to give the total 300 IU. So this is one very very simple thing what we'll say. So Dr. Sonal, this is, I think it has been covered. RH negative, husband RH positive, ICT अभी discuss हो ही गया कि क्यों करना है. And that's why it can be the undisclosed pregnancy, many things. इस समय हम दूसरी चीज़ जो हम कर सकते हैं, what is the quantitative estimation? What we can really think of it that when the husband is RH positive, it is very cost effective to get that homozygosity. क्योंकि अगर वो heterozygous है and homozygous है, then every baby will be RH positive, every baby need this thing like monitoring. If it is heterozygous, then 50% will be RH negative. So I will like to have everybody's comment on it. Two things, हम लोग NIP बहुत हमारा एंटीनेटल केयर स्क्रीनिंग प्रोटोकॉल बढ़ गया. सो 2 गैप्स इन इट हम लोग जिसको शुरू कर सकते हैं. वन इज द हैविंग द हस्बैंड homozygosity, heterozygosity, and if it is any adverse obstacle outcome जो कि अभी हम लोगों ने केस डिस्कस किए, that is the time if the husband is heterozygous we can take advantage of NIPT to get the fetal blood group. If fetal blood is negative, no intensive monitoring, nothing NTD, and if it is positive, then intensive monitoring. So what's your comment that it is the thing which we can really start?
We can actually start it because we are doing it and we can actually start this thing.
He does only histopathology and cytology now for many years. So when I said down whom to shift over as far as blood tests are concerned, so he said you should go for Lals because they have a reputation. कोई गलती नहीं, ये कोई गलती करेंगे तो फिर वो भुगतेंगे ना. आपने जैसे कहा ये मैंने तो कहना नहीं टेस्ट नहीं, पर डॉक्टर साहब आप नहीं डॉक्टर साहब they will sue the lab. They will sue the lab. डॉक्टर साहब मेरे साथ एक NIPT हुआ था, वो कहा था नेगेटिव है, उसके जब हो गया तो बच्चा तो डाउन सिंड्रोम वाला बच्चा निकल गया, तो वो कहा उसने दुबई में कराया हुआ था कहीं से. बट द क्वेश्चन इज यू मस्ट नो फ्रॉम वेयर यू आर गेटिंग द टेस्ट डन.
Then the follow-up is only MCA-PSV. Then the follow-up is only MCA-PSV, not titers anymore.
So sir,
Then the titers, then the
actually,
follow-up.
actually this story will be unending. But just I want to say the ground problems with the thing, because actually the intrauterine transfusion, that is something which our expert have. So one thing is this lab quality, and we have to be repeat and say that for medical legal. And second again, then MCA PSV, again what I emphasize, it requires special skill. It is not only the angle, plane, the setting of Doppler tone, it is also statistical analysis. So 1.5 mom, 2 mom. We are getting actually too many, like we don't know what we know. Sabne bola 1.5. What does it mean? Gestational is specific, weight is specific. So there is the thing, and Dr. Harsha and Dr. Any difference of opinion? 3 week and 4 week. मान लीजिए 3 वीक नहीं 4 वीक, तो कब उसको रिपीट करना है?
3 वीक्स तक वर्क करती हैं एंटीबॉडीज, उसके बाद देना ही देना.
4 वीक के बाद
देना ही देना.
So this is important. If she has recurrent bleeding, you can repeat the dose after 4 weeks. So this is again a very, very common thing. Critical titer, I think 1:16 is the thing. Important for obstetrician. RH negative patient, she is in labor. So what precaution do you have in the cesarean section and during conduct of delivery?
We consider that the RH negative woman is a high risk patient. So these patients need continuous fetal monitoring. And in the hospital setting, there could be fetal anemia. So just keep an eye on the fetal heart. And then you have to check for availability of the blood in your blood bank, because she may require blood. And you have to see that you have exchange transfusion facilities in your center if the baby...
Actually, what I wanted to say that the labor room practices that no methergine to be given, and like if there no excessive manipulation, and if you think that it has been a... Yes. So I was actually looking for that simple things.
No, what you should do is, you cut the cord on, hand over the baby, don't clamp the maternal side. लोग समझते हैं PPH हो जाएगा, नहीं, ये तो blood is in the placental unit, that will flow out, and you know हमारा आदत है ना clamp करके ऊपर रख के episiotomy stitch करो. That is the wrong thing.
So this is the few labor room practices which was once upon a time classical teaching, but now we are so technical, we are talking like na, we are thinking of the last thing first. And always RH negative, what Dr. Sonal says that she is a high risk, so the blood availability anytime. RH negative people are special. So one thing, good labor room practices to prevent the feto-maternal more isoimmunization. And if you think that it is higher, either we do this quantitative test. If it is not there, then on the basis of your experience, you can add 150 NTD again on.
But one preparation for everybody here is what samples you will take after delivery.
Yes, for the baby.
From the baby side? Yeah, okay, for the baby, we do the blood grouping first, and then we take the hemoglobin, hematocrit, peripheral blood smear, plus DCT, plus serum bilirubin.
DCT. Albumin is not necessary, but DCT has to be done.
DCT is there. And serum bilirubin is also taken, madam. EDTA sample for DCTV2.
So always keep RH negative है तो सिस्टर को पता होना चाहिए कि हमारे पास
वायर
वो
रखनी
वायर्स
है।
रहनी है. So this is very very वो सब हमारी रिस्पॉन्सिबिलिटी है फाइनली. लेकिन वो वायल्स ये नहीं कि सीजर हो गया तो ढूंढने जा रहे हैं लोग वायल्स को. सो दिस इज वेरी इंपॉर्टेंट दैट एट दिस मोमेंट द ऑल इन्वेस्टिगेशन टू बी सेंट. Does yes, this is what we say. So any postpartum NTD, what is how late is too late? So it is, I think the question has been answered. Maximum 28 days.
28 days.
तो आपको कुछ तो देना है जिससे कि कुछ तो पेशेंट को फायदा हो.
So this was actually a question which you had made extra and you had written over there. If there is a fetal medicine specialist, maybe Harsh can talk a little bit among the panelists. When to repeat, mode of delivery, timing of delivery. Okay. So we talked about subsequent delivery, subsequent transfusion will be depending upon the post-transfusion hematocrit, and usually we need to do it every 3 weekly. And 3 weekly till the baby is 34 weeks, we have made it a tradition in AIMS that we will do the last transfusion. ऐसा करके time करते हैं कि around 35-36 weeks ताकि next 3 weeks nikal jaye and the baby will be delivered at 38 weeks. And the mean rate after every transfusion, as Dr. Vandana had said, that the PSV is different. So we did a lot of theses, you know. We have hundreds of RH isomerizations. So monitoring after second IUT, the fall decreases. Then monitoring after third IUT, again the fall decreases. 0.2, what we used to say. So that's. So, and you know, this is what I was saying, Dr. Sharda Jain has left. But when I was chairman of the Genetic and Fetal Medicine Committee of FOXI, 2007 to when was I? 7 to 10, yes. Every weekend I was out, traveling like her. And the one thing that I was telling to people in the country was, please don't refer wait till high drops. Refer as soon as ICT is positive. And I'm very happy to say that the referrals for high drops decreased. So we were getting, and the period of gestation, what we were doing in 80s, you know, 88, 89, we were as soon as 32, 34 weeks ho gaya, because we were not very confident about doing transfusion and having an IUD at 32 weeks. You know, we felt very guilty about it. We were just not confident, that's all I can say. So we used to deliver at 32, 34 weeks and pediatrician will manage now. Hamara kaam khatam. You know, we was like sitting on a thing. So then we became confident with thing, and now we started, after that we started delivering them at term. So, and then our neonatal, hydropic and non-hydropic prognosis is so different. Because as Dr. Harsh said, hydropic babies will die, you know. So this was our thing that just compared the difference between a hydropic and a non-hydropic over the years. So over the years, we became more and more experts. So I'm very proud to say that in 2016, our unit had done 1,000 intrauterine transfusions. And it came in the newspapers and everything, so 10 years back almost. So it all depends on expertise and practice.
Media awareness should be there for all these things, otherwise that is the reason why we doctors are losing the importance. We don't say that we have gained so much. And those gains have to be repeated again and again in the media. So they know that what amount of work is being done. For us it is important, you are telling us. Still the general public doesn't know. So they should know about
But
it.
it was in Hindustan Times, it was in Times of India.
No, but it should be repeated at times, like...
Not absolutely. We have a good, kuch hai, like there are many things about. Before going to this intrauterine transfusion, which actually keeps very interesting, I will say again we keep on this NTD titer, but before we do administer NTD, it is must that we are sure that NTD, ICT is negative. So that is very important, and after that we stop doing ICT. So this is something important, क्योंकि patient आता है ये नहीं 28 week पे कह दिया, and after that we stop ICT doing.
But 10 weeks पे हमने दिया तो ICT stop कर देंगे.
नहीं करेंगे वो 1:2 1:4 होगा या नेगेटिव भी होगा एंड समटाइम वी रियली नो कि आईसीटी हाँ सो वी हैव टू 10 वीक पे आपको करना है लेकिन एंटीडी देने के बाद फिर 28 वीक के बाद नहीं करना। दूसरा एक प्रैक्टिकल चीज़ है कि कभी कभी पेशेंट ये रहता है ना कि उसने आज लगाया और 3 दिन बाद वो लेबर में आ गए। सो व्हाट इज रिकमेंडेशन लाइक टू हैव ओपिनियन डॉक्टर डेका बस इफ इट इज़ विद इन 7 days अगर एंटीनेटल लगाए देन इट इज़ दे मतलब इट इज़ समथिंग दैट इट इज़ नॉट नीड टू रिपीट पोस्टमार्टम। सो व्हाट्स योर टेक? सो वेरी वेरी कॉमन थिंग्स व्हाट वी आर हैविंग उसने 7 दिन लगाया वो बीच में लेबर में आ गए और अगर है
Then
तो
we
फिर
don't
लगेगा या नहीं तो वो नहीं लगेगा इफ इट इज लेकिन अगर 1 महीना है 28 अगर 32 पे आई तो लगेगा। सो दीज आर फ्यू
Okay, I think we have to go fast because
Yes.
Kiran is looking at me with big eyes.
It's already 5 p.m.
Yes.
Yeah.
Dr. Vandana.
We are running very
I
late.
think some of the things are
And
coming a little bit of
again,
repetition. No, not repetition, we're discussing.
Right.
So, already discussed.
So the patient has had an ICU immunization in the previous pregnancy. ICT will be the only one. First ICT we get to know what are is it
Yeah, we
positive
don't
or
need to
not,
repeat
and then we
ICT.
go do the
Yeah,
titers.
we don't
and-
have to because she's already immunized.
Yeah. No,
If
we don't
antigen
have to
not
give
given-
a prophylactic ICT. We will not give her prophylactic dose. But if there is a sensitizing event, that has to be covered, even if she's
Okay,
ICT
the question was
positive.
different actually. Now this one is antenatal entity not given an Rh negative woman. What is the risk? I think we've already covered.
Yes.
We've covered it. Does prophylactic crossover to the fetus? We already covered, not covered really. Are you scared of an ICT titer of 1 in 4 causing anemia in the baby?
No.
1 in 8?
No.
Okay. Entity given is antenatal period. Again, what is the risk of immunization? We've already covered. So, does a mother? No. Yeah, mother can become immunized, but not critical. Well, at this point, I want to say rarely. You sometimes give very high dose because we had cases, you know, accidental hemorrhage, baby, absolutely, middle, the sinusoidal pattern. We give 4 injections. So, beyond 4 is not to be given. So, why does an ICT become immunized during pregnancy? We have discussed already. And we have also discussed this, isn't it? Yeah. This should, Claire Hobbit, somebody sent this question yesterday also, should be done in all deliveries for quantification. Is it necessary?
Should we do that?
No, we discussed yesterday actually.
Should we do
We
the clear
don't need to do it because we are anyway giving overdose of anti-D. You know, fetal-maternal hemorrhage is never more than 1 or 2 ml. And we are giving something which covers 15 ml, 30 ml. So, itna zaruri nahi hai unless the babies are pale, there is evidence of silent massive fetal-maternal hemorrhage. Claire Hobbit test you can do. Actually, it's not difficult as Madam said. When I was doing PG, my co-PG's thesis in Guwahati Medical College was Claire Hobbit test. All so simple hai ye. And we used to really enjoy sabke blood leke se dekh ke, you know, as a PG. Just like for fun. We used to do Claire Hobbit test. It was his thesis and we were doing it. So this is the question that you asked. Somebody asked, prognosis kya hai? Batayenge Dr. Harsh. So this was our data. I have data much, and I am so happy to say that it is comparable to the best centers in the world. And we have given transfusion starting from 16 weeks, and intravascular, intraperitoneal, and this is the amount of blood that we need, you know, and complications. Preterm labor, transient bradycardia, displaced needle, and premature rupture, these are some of the problems. These are usually multis. So people think, bhai, RH, IUTs kiya, iska cesarean karna hai. No need. They can deliver vaginally. And this was the later data of 2011 to 14. We had so many, 102 fetuses. And look at the percentage of survival. Hydropic, non-hydropic is 93.8 and hydropic is 90%. So we became better. That's all I can say. Now, there was a question like somebody was asking and I said we'll discuss later. Alternative management to severe RH isomalized pregnancy. You've done transfusions in previous 2-3 pregnancies. Kya karenge? So, in fact, I had the wonderful opportunity of doing WHO fellowship This is Quinan. You all know him as the Quinan's chart on the left side, and right side is Sacker. He was the one who published the first article, and that's why I chose that center. Of course, government only gave me the center, so I had to go there, and he was so meticulous. The moment I went, he took out his paper and he gave it to me, and he was the first person to introduce IVIG therapy for RH isomerization. And this is, we have published this paper. Aparna Sharma, who is now additional professor, she was with me as a pool officer for 3 years, after her senior residency with me for 3 years. And I gave her this thesis, that during transfusion we give IVIG. And IVIG, what it does is coats the fetal RBCs and prevents them from getting hemolyzed. We found that the transfusion required was very less. For one transfusion it used to be. Like otherwise we would have had to give transfusions every 3 weeks. It became like 6 weeks, 8 weeks, and sometimes not even required. So we found it very, very useful. No, this is, see, because you're giving the mother 400 milligram per kg body weight, it comes to 1 lakh. I developed a technique where I was giving only 400 milligrams. This you're giving to the fetus. So fetus is only 500 grams, 600 grams. 10 ml is enough. 10 ml is hardly 1,000 rupees. Yes, direct fetal intravenous immunoglobulin therapy. Last resort, of course, when severe, I have had one patient in my life whom I said, ki nahi ho sakta hai, because I did 3 pregnancies, transfusions to the best of my capability, but she was very highly antigenic. Within a week, she used to come back again with high drops. And I advised one patient NTP ligation and one patient, because she already had a child. And the other patient, I said, IUI donor with RH negative. But there was a very funny story with that madam. She IUI to kar diya, RH negative, but then I told her that you must use condoms with your husband. Oh my God. She got pregnant with her RH positive partner. And again she landed up. So this is a 34-year-old. We'll just go rapidly now. A history of blood transfusion, dengue. Received platelet transfusion. Can it cause immunizations?
Yes, it can.
So how will you prevent?
Again, the same procedure we do. We do ICTs for her. We do titers for her.
No, you're giving the blood transfusion, platelet transfusion. Na? We are so often giving platelet transfusions for dengue. Are we doing blood group?
Yeah, so it should be ABO-RH matched and compatible.
Yeah.
So
you know, in this era of platelet transfusion, we must give anti-D to the RH negative woman.
This has already been answered.
Right. Then I'll just quickly go. We said ICT 1 in 8. We will just follow up. Critical titer is 1 in 16. So this is the one. Should we repeat after you have a titer? Should we repeat?
See, 1 into 16 in first pregnancy is rare.
Yeah, third pregnancy case hai?
Yeah, third hai, but first we will not repeat and we'll take it as a high-risk pregnancy and we'll follow up like that.
You will now refer to a fetal medicine specialist.
Yes.
Yeah. So then you refer and then you monitor. Refer to a center with expertise in invasive fetal therapy. You know, who can do that. Okay? And middle cerebral artery, we monitor when we get a patient of RH isomerization. And there are a lot of Doppler studies which show that middle cerebral artery is very, very sensitive. You know, and this is a Mari's chart. In this, we actually, with different periods of gestation, we have the hemoglobin PCV correlation. So at any time, we find that it is more than 1.5 MOM, you need to do a, so there are many charts which tell us that this middle cerebral artery peak systolic velocity has reached a dangerous level and we have to do a transfusion. So intrauterine transfusion should be done when the MSPV is more than 1.5. So what percentage of women can be insufficiently immunized after delivery? I think we already talked about it. We have still a high group and this is ultimately is too difficult to see, but summary of what we just discussed. So, in conclusion, fetal anemia is an emergency, and we are still seeing these cases. Successful management is by ultrasound monitoring and intrauterine transfusion. So, thank you all very, very much.